instruction, if you see that the patient comes with a chronic productive cough, that means you are something looking for the bronchiectasis. If your patient comes with the dry cough and gives some history of joint pain, that you are looking for the interstitial lung disease. And if any patient with chronic breathlessness, you look for the COPD. Okay, so instruction is very much important. After that, just you go wash your hand and go to the patient and say that, hello, I'm Dr. Rahman. I'm the doctor of this clinic. I've been asked to examine you. Is that okay with you? Okay. Like in the other station, don't say just I will ask only the chest, because you have to look a lot of things. So before doing examination, do you have any pain anywhere in your body? No, doctor. So if you feel any pain or discomfort during my examination, please let me know. I'll be gentle. Is that okay? Okay. Now, what you will do, you will expose the patient. So if the patient is elderly patient, say, I want to expose your chest, please, and may I help you to uncover or take off your shirt? Then patient will take off his shirt. If you think that if the patient is female, then you will ask the female attendants who will be present there for the uncover the dress, for the uncovering the patient. For exposure, just request him, just I want to take off the shirt or take off the gown. Okay. So the female attendants do it for you. During this exposure, you have to check something. What? Like in the abdomen station, before after exposure, just immediately you check the scar. Here you also notice, is there any scar present or not? Okay, so it's very much important to find out any scar present or not. Because if you find any scar that is very clear from the front and no scar in the back at all, then you will start from the front. And if you find there is a scar which is starting from the back, so it's better start from the back. Another thing is that you enter, after entering the station, you think after at a glance you see that this patient is a typical patient of ankylosing spondylitis. So it's better start from the front, because you will check the apical fibrosis here. So it is more clear from the front. Another patient, during exposure, you discover that patient has typical features of rheumatoid arthritis. Fingers are deformed and there is a Shovan neck or butternut deformity. So it's better to start from the back. So you will find the findings easily. Yes, definitely you will do the other thing. Just start from the, if you start from the front, definitely you will do the back. But sometimes it's happened that there may be some shortage of time, because you have to look a lot of things at the same time. You have to identify the finding. Okay. So what you will do, you just check is there any finding in the hand or any finding in the spine or ankylosis present or not. If you don't find anything, just you lie down the patient and always start from the front. So this is the advice to you. If you find some clue, again, that is this ankylosing spondylitis, it's better to start from the front. If you find some clue that is connective tissue disease, it is better to start from the back. Whenever you start from the back or front, every time you have to cover the all things. But if you start from the back, then you can check the back clearly, more clearly. Okay. Then think that this patient does not have anything, just ask the patient to lie down or in supine position. Then you will just look at general examination, just a general observation, not examination, sorry, just you have a general observation. Here in the general observation, you will check the patient carefully to see two things. Either is the patient is in distress or not. Is the patient is in distress or not? How will you check the distress? Number one thing is, if any patient of breathing difficulty actually will not present in your clinical station, because a lot of at least five examine will examine her, it will be stressful for him. So if but there is a possible a patient have some breathing problem may come in the exam. So you may find some tachypnea or prominent accessory muscle or in the suprasternal or supraclavicular or substernal recession. Okay. And at the same time, you will check for the any scar. So you will expose the patient, you will ask the patient to lie down, and just you will go to the general observation about the patient and as well as the surrounding. For the patient, you will check is the patient is in distress or not. From you will see the prominent accessory muscle, suprasternal, supraclavicular, and subcostal recession, tachypnea present or not, and you will see any scar is visible or not. Now you will going to start the examine the patient. You will going to start the inspection. Going to start the inspection. Okay. So here is better to start the examine the patient from the hand. So at first you have done some general observation to the patient. Now you will start from the hand. In the hand, like every patient, you look for something. In the hand, what you will look for? Just for clubbing, any clubbing, and nicotine and a nicotine stain. So any clubbing and a nicotine stain. Then you will check the hand flapping tumor. Okay, so clubbing, nicotine staining, and flapping tumor. Then you will check the pulse. You will check the pulse of the patient. Pulse. And during so you will check the pulse only 10 to 15 seconds. After that, at the same time, it's better to check the respiratory rate. So you will check the pulse at the same time, you will check the respiratory rate. And during this time, actually hand examination, you will check the is there any rheumatological feature present or not. Is there any rheumatological feature present or not? And from the beginning, if you think the patient is Cushingoid appearance, that means there is some facial plethora, some acne, and patient is during exposure, you notice there is a truncal obesity. So it's better in the hand, we check the thin wasting or look for any screen buoys. So if you find some finding in the patient is Cushingoid, if you think this patient is Cushingoid appearance, then it's better to check the any thin wasting or any skin rash like any eczema. Any skin rash, erythematous skin rash. So if you check the hand, check the pulse, at the same time you will check the respiratory rate. Now you will go up in the eye, you will check for anemia and jaundice. In the eye, you will check for anemia and you will check for the jaundice. And now you ask the patient to open the oral cavity and you will check the cyanosis. You will check the cyanosis for central cyanosis. Okay. And it's also present, no cyanosis usually will not be present in your exam. Now you will check the neck for any neck vein. You will check the for neck vein, that means JBP. Here you will just observe any prominent neck vessel present or not. Prominent neck vessel is present or not, but you don't need to examine the JBP properly. You don't need to do the just you check the prominence of the neck vessel. And if the patient bed is 0 degree, so you don't need to do the bed 45-degree angle. Just you will take permission from the examiner. Just I have to check the JBP in 45-degree angle, because if you want to see the JBP, then it will take time. Better if you think this gentleman is having some form of pulmonary hypertension, you will do it later. Okay. So after that, what you will do? You will now do the inspection. So you will do the inspection of the chest. You will go to the chest proper. Okay. In the inspection, again, you have to look for any scar. So you will do inspection from the front and from the side, that means below axilla, the axilla, and as well as in the back, So you will check front, side, that means axilla and back, to see any scar. Okay. Later I will say about different types of the scar. So you will check the front, side, and back to see the axilla. So just I'm going to look your chest. Is that okay? Okay. The front, then look at the right and left axilla. Would you please roll in the right side as well as roll in the back side to see any back scar? Okay. Okay. After that, what you will do? You will just there is no scar. Just step one or just back one or two step towards the leg and ask the patient to take a deep breath in and out. To ask the patient one or two step back towards the foot end and ask the patient, please take a deep breath in and out. So you will check the symmetry. So you will check now symmetry. For that, please take a deep breath in and out. So patient will take a deep breath in and out, and we will check the chest symmetry. Any movement of the chest is symmetrical or not. At the same time, you can check any chest flattening present or not. So you will check now symmetry as well as any flattening of the chest present or not. And after that, what you will do, you will ask the patient to make a cuff for me. Can you please make a cuff for me? So why you will ask this? Again, you will ask the patient, can you please make a cuff for me? Now patient will be patient will make a cuff for you, and here you will get a clue. Number one, if patient is dry cough, at that time it may be fibrosis, or the most important thing is that if the patient is in bronchiectasis, if it is the patient of bronchiectasis, he will make multiple cough at the same time, multiple cough, and patient may need sputum port. Okay, so just what you will do, you will you'll ask the patient to please take a deep breath in and out. Okay, that's good. And please, would you please make a cough for me? Patient will give a cough. Sometimes patient will give multiple 2 or 3 cough. That is dry cough. It does not have. But sometimes patient will give a cough, and patient will produce profuse amount of the sputum. So that is by this way you can understand actually it is a case of bronchiectasis or suppurative lung disease. Okay. So what we will do next? Now you are going to palpate the patient. Now you are going to palpate the patient. For the palpation, what will you check? The palpation. The palpation, you will start from the trachea. It's better to start from the trachea. If the patient is in lie down in supine position, in palpation, start from the trachea. Just you will place your index and ring finger in the sternocleidomastoid border, and you will check the tracheal position by your middle finger. Okay, so you will check the trachea shift or not. Now what you will do? Now you will check the chest expansibility. So you will check the chest expansibility. So you will place your hand just above just below the clavicle and ask the patient, please take a deep breath in and out. So please take a deep breath in and out. So you will check how much your finger separates. So this is the palpation. So at first, what you will do, you check the position of the trachea. Next, you will check the chest expansibility. So in chest expansibility, you will look for 3 areas. Okay, just just below the clavicle, number 1, and at the position of the nipple, and just below the nipple. Okay. So you will check the chest expansibility in 3 sides, just below the clavicle, and at the nipple, and just below the nipple. So in 3 area. Then you will have what you will do. You in here you don't need to measure any chest expansibility. Okay, just you will ask the patient, please take a deep breath in and out. By this way, now what you will do? You will do the percussion. Previously, patient it is advised to do the vocal frequencies, but nowadays it is absolute. You don't need to do the vocal frequencies. So what you will do, you will do percussion. And regarding another thing, sometimes they give someone asks to check the uh, apex beat, but it is not necessary all the time. So it is not usually it is not necessary to do or to check the apex beat. So now you're going to the shift to the percussion mode. In the percussion, you will tap over the you will if the patient is in lying down in the supine position, you will tap both in the front and in the axilla. So you will tap both in the front and in the axilla. In the front, you have to cover 6 intercostal space. So in the front, you have to cover 6 intercostal space. So just 6 intercostal space. So what you will do, you will tape just above the clavicle, start above the clavicle, okay, and then after the 5 intercostal space, okay, just above the clavicle, then below in the 5 intercostal space. You can check it in jet manner. That means from start from the right, then left, then right, then left in this, or right, left, left, right in this way. So whatever you choose, you can do it, but you have to identify the finding. So in the front, you will check the 6 intercostal phase. That means just above the clavicle, then 1 space below, or then second, third, fourth, this way 16 up to 6 intercostal space. Okay. Now you go to the axilla. In the axilla, so you can from the 4th intercostal space to the down. That is 8 up to 8 intercostal space. That means 4 space. In this 4 space only, you will tap for the 4th time. So patient is lying down in supine. In the front, you check in the 6th intercostal space. 6th time, you will tap in the 6th time, and in the axilla, you will check for the 4th time. Now, what you will do? Lastly, you will do the auscultation. Auscultation. In the auscultation, again you will do the same thing. At first, what you will check? You will check the breath sound. You will check the breath sound. Either it is vesicular or bronchial. Next, you will do the check the vocal resonance. So at first you will check the bass sound, then you will check the vocal resonance. During check the vocal resonance, ask the patient to say 99. Okay, to say 99. And what you will do? Now I am going to check the your vocal resonance. So when I put my stethoscope into your body, just say 99. And at the same time, you can say, okay, just say 99, say 99. By this way, you can check the, you can do the auscultation. After that, after checking the vocal resonance, just ask the patient to sit down. Ask the patient to ask the patient to sit down. Okay. Then what you will do? You will examine the patient from the back. So you will examine the patient from the back. And in the back, again, you will at first you will check the chest expansibility. Okay, you will check the chest expansibility, and again you will place your finger in the again in the just the above the clavicle. That means you will check just upper part, middle part, and the lower part. Okay, so upper part, middle part, and the lower part. So check the expansibility, and every time you have to say, please take a deep breath in and out. Okay. After that, what you will do? You will do the percussion. You will do the percussion. Here you have to percuss in three area. Here you have to percuss the 3 area, and you will always avoid the scapula. Okay. You will percuss in the 3 area, and you will always avoid the scapula. So you will percuss in 3 area, and you have to avoid the scapula. So how you will percuss? Just at first, you will do an percussion just above the. This is the chest from the back. Okay, so just you will do percussion one time there, and this is the scapula. So you will do one time, and then just beside the scapula for 3 times, and then again below from the scapula for the 3 times. Okay, from the 7th intercostal space to 10th intercostal space. Okay, so here you will do percussion for the 7th time. So just upper part of the scapula, then you will go medial aspect of the scapula, and then the lower part of the scapula for 3 times. So you will do percussion for total 7 times here. After that, you will do the auscultation. Auscultation is the same way. You will put your stethoscope in this 7 area, and every time ask the patient to take a deep breath in and out. Okay, and you will after that you will check the vocal resonance. During checking the vocal resonance, ask the patient to say 99. Just say I'm going to check the vocal resonance. So what you do when I place my stethoscope over your chest, just say 99. So at the same time is better, you will say 99. So place your stethoscope, then say please say 99. Okay, again 99 again. In this way, we will do the auscultation. So in this way, we will do the auscultation. And another, so we have completed the chest examination from the front, and we have completed the chest examination from the back. Now, what we will do, we will go to that again front of the chest. We will go again front of the chest. Front of the chest, what we will check? If think that this is a case of ILD or any advanced disease, so we have to check any features of pulmonary hypertension, any feature of pulmonary hypertension. For that reason, we will check the left parasternal heave, and any P2, so any loud P2 or left parasternal heave. So we'll again come in the front, and we'll place our medial aspect of the finger into the patient left side to feel the left parasternal heave, and then we by the stethoscope, we put the stethoscope directly in the pulmonary area to heard any loud P2. Okay, then we'll go down. We will down to check the leg for any peripheral edema. Okay, so we will go down leg to the any peripheral edema. So by this way, we will complete our examination. So actually, it's very easy to say, but reality is that it takes a long time to complete this this examination. So we have to be very very quick and focused, and we have to know that which is more prominent, because when we do the exam, we have to give more time during auscultation, because it is the key, it is the main, as well as during palpation we have to more focus on the trachea. So the position of the trachea is very much crucial, because we cannot check it by auscultation, and during auscultation we have to take more times. If during identification of finding, if anytime we feel any difficulty, we'll check it. We'll check that area 2 or 3 times, because if I miss the finding, everything will be missed. So if I think that here is the finding, the right, lower, left, and I'm confusing what is the finding, check it multiple times. Takes at least 30 seconds or 40 seconds there. You don't need to do everything. You are starting from the back, and you are facing any difficulty in the right lower zone. Then you will check this area multiple times to identify actually what is that finding. Then in the front, just do 1 or 2 things. You don't need to do the everything if you are correct. Okay. Then if you think you have shortage of time, you don't need to check even the chest for the heart. You don't need to see the pulmonary hypertension. Just go to the leg, check the peripheral edema. Okay. So in this way, you can complete the physical examination of the respiratory system. And so do you have any query about this, any examination technique or any other advice? Any query?
Sir, yes, sir. Left parasternal heave. How we check that?
Okay, we'll just put our medial aspects of our palm, okay, over the patient, left, third, fourth, and fifth intercostal space, and we'll check the left parasternal hip present or not. Okay, and it is very in a respiratory case, it is very tough to find the left parasternal hip. And if you check the all the stress station comes in the previous patient, you will not find that anyone got this left parasternal hip in this patient. So we also does not get any hip.
Excuse me, sir.
Yes.
Yes, so you said that if we go inside and on inspection, there is a clue of rheumatoid arthritis. So we will start from the back, right?
Yes, yes.
And if there is clue of ankylosing spondylitis, which could be like patient can have kyphosis or anything like that, then we will start from the front to look for apical fibrosis,
Yes.
right?
Yes. Yes, yes,
And
you are right.
can you, sir, please repeat, because in the start my internet was not stable. What could be the command? What could be the different commands
Yes, yes.
for
I'm just
respiratory
saying
station?
the different commands again. Oh, okay. So at first we will go to the patient and we'll check the instruction and we'll say, hello, I'm Dr. Rahman. I have been asked to examine you. Is that okay? Okay. During my examination, if you feel any pain or discomfort, let me know. I'll be gentle. Okay. Could you please, I'm just go fast. And now I have to expose the patient. Okay. So would you please take off your shirt, please? In case of female, there will be female attendants. I will ask the female attendant. I have to expose the patient. Expose the chest, hold. Okay, female attendants will do it. Okay. During exposure, I will check something. Number one, I will check the patient hand. Is the patient is in some distress or not? Then during this time, we'll the thing I how we'll check is the patient is tachypnea, prominent accessory muscle or not, or I will check all those the scar. Okay, so I will check two things during exposure: patient is in distress or scar. And sometimes we may get some peripheral clue. There may be oxygen cylinder, there may be a nebulizer machine. So that also gives some fluor inhaler or sputum form. Okay. Now I will start from the and if there is any features of any rheumatology, I find there is a features of rheumatological hand. So there will be if anyone, so what is the easiest case in the respiratory system? If any patient with rheumatology, rheumatoid arthritis in the hand, DPLD in the lung, this is the easiest case. So it is if any patient has DPLD, that will be Erzban deforming arthritis. Then during lung expansion, I will find the DPLD, and it is better to examine start from the back, because if you check the DPLD patient, actually from the front you will not find anything. So when you check the basal zone, you will find the crackles. Again, if you think this is a case of ankylosing spondylitis, advanced case, if you ask the patient to lie down, he will not actually lie down properly. So it is better to start the patient from the back, from the front, and it is better to do examination in the sitting position in case of ankylosing patient only. And in other case, what we will do, we will ask the patient to lie down supine position with exposed chest, and we will start from the hand. So I will ask the patient, may I check your hand, please? From the hand, again, clubbing, nicotine staining. Okay, can you do just like this? I will do that to check the patient, flapping tremor. Okay. Straight your hand and cock up your wrist back. Yes. Then I will check the flapping tremor. Now I'm going to check your pulse. Is that okay? Okay. I'm checking the pulse. At the same time, I have already observed is there rheumatological change present. Okay, I'll go up. I'm going to check your eyes. Is that okay? Okay, please look up for me. Okay, look down for me. Okay. Now I'm going to check your mouth. Okay. Could you please open your mouth? I will check with the light, and here I will check any cyanosis present or not. Then I will again go to the, now I will go to the chest. First I will do the inspection. During inspection, I will check any symmetry present or not, or any chest flattening present or not, any chest scar present or not. I will ask the patient to roll right or left side to find out any scar present or not. Okay. Then what I will do, I will just go back. 1 or 2 steps. Ask the patient, please take a deep breath in and out towards the, is better towards the foot end. So please take a deep breath in and out. Here I will look again the symmetry of the respiration, and any flattening chest, flattening present or not. Now what I will do, I will ask the patient to make a cough for me. Would you please make a cough for me? Then patient will cough. See, if this is a case of bronchiectasis, here is the clue. If this is a case of bronchiectasis, what patient will do? Patient will cough. Patient will make several cough. And in case of advanced bronchiectasis, patient may need sputum for. Okay, so what he will do? He will be a lot of cough, and he will search for the sputum for. This is in case of bronchiectasis or suppurative lung disease. Okay. In case of interstitial, the patient may give multiple cough without any sputum. Okay, but in normally patient may cough. Normally patient will give only give the intentional cough. But in case of the both ILD and the bronchiectasis, when patient start to cough, he will give several cough at a time. So it is actually a clue to identify the patient, actually what may be the finding. Okay. Then we'll go to the patient and ask the patient, now I'm going to feel your neck. Is that okay? Okay. Check the trachea. Now I'm going to feel your chest. Is that okay? Okay. Now check the chest expansibility. In the at first over the clavicle, at the position of the nipple, and lower end of the chest. 3 positions. Then I am going to percuss. Now I am going to tape over your chest. Is that okay? Okay. So in which area? What I will do at first is better just over the clavicle, and then I will go in the 6 up to 6 intercostal space. So over the clavicle, just see the apex, then first page, second page, even up to 5 page. Just below clavicle, below nipple, you can get 1 or 2. Okay. In this way, we will check the percussion load. In this way, we'll check the percussion load. After that, what we will do? After that, we will do the auscultation. In the auscultation, again, in the percussion, we have checked the front. Now in the percussion, we have to check the axilla. In the axillary area, from 4th intercostal space to 8. So it is 4, only in the 4 area. Front 6 area, laterally 4 area, and back up to, we have to do it for 7 times. Okay. So in the 4th intercostal first to 8. So we will do it in the 4 area. Okay. Now we will do the auscultation by the same area. During auscultation, take a deep breath in and out. Okay. Now vocal resonance. Okay. So when I put my stethoscope, just say 99. Okay. In every time, put the stethoscope, say 99. Yes. Again, yes. Again, yes. Again. And this way, we'll check the vocal resonance. Now, what we will do, we will ask the patient to sit down. We will immediately go to the back. Ask the patient to sit down, go to the back, and inspection. I have already done, don't need to do inspection again. So chest expansibility. Okay. Percussion. In here, we will do percussion in the 8 area. In the 8 area, just above the, and here the main key is that we have to avoid the scapula. So what we will do, we will ask the patient to hold the opposite shoulder in cross hand. Okay. So hold the opposite shoulder in the cross hand, then it will shift the scapula towards the lateral. Okay. So one percussion over the scapula, then in the both medial aspects of the scapula, that is in between the scapula medial border and the vertebral body, 3 space, and just below the scapula, 3 space. That 1, 3, 3, 3. We have to do it in 7 space, and we have to auscultate this 7 area, and after that we have to check the vocal resonance in this 7 area. Then we will going to immediately, if we think it's a chronic process or I have enough time, I will check for any features of pulmonary hypertension and vocal resonance and loud P2. Okay, go to the leg to see any peripheral edema. In this way, I'll do my respiratory system examination. Here, some alternatives also present. Look, if I think this is the features only of pleural effusion, only pleural effusion, so I will not go for in the to check the. I think this is a case of pleural effusion, and it's a clear cut. So I will not check for the features of pulmonary hypertension. Rather, I will go up in the neck to see any lymph node, to see any lymph node present or not. Okay. So any question?
Sir, just one thing you said, we don't need to see the JVP if patient is lying down.
Yes.
But
Yes.
if
Yes.
patient has edema, pulmonary peripheral edema, and the signs of fluid overload, we need to see JVP at 45.
Yes. If only the patient is peripheral edema, at that time we will see the JVP. But
So,
usually, yes.
So what stage we will see after seeing the back and front, or before
After
front?
seeing the back and front, because what you need the complete diagnosis, and this is a chest case, and if you observe the whole chest case, what comes in the places before, so you will not find there someone find there is a DPL with the features of pulmonary hypertension. It's a very rare happening. Okay. And in connective tissue disease, patient may develop pulmonary hypertension, but you will find some other things also. Patient may have possibility of heart problem.
Hepatojugular
Hello,
reflux.
sir.
Yeah, yes.
Sir,
Sir,
we will do hepatojugular reflux.
I will not do hepatojugular reflux. Look, if you want to see the JVP, it will take at least 30 seconds. The real thing is that you will not find enough time to check the JVP. Okay, so if you
And
do
sir,
the front, axilla, back, it will take time.
And sir, if we think that we need to examine JVP, we should always ask the examiner. If he says no need,
Yes,
then
yes,
okay, right?
yes, you are right. It's
and sir, about epic speed, we want to check it for dextrocardia, right? Where it's applicable.
You are right,
Epics.
but if you want to check dextrocardia, actually it's not so easy, because
For
in normal
cardiogenic
patient, if you
syndrome,
check
sir.
the apex, which is so yes, but you don't think that if you check the previous status, just you will find the features of bronchiectasis. Okay, then
Right.
examiner may ask the question, what we want to see else. So if you, so what in reality what's happened? If any patient, obese patient, and they give the obese patient took the apex width, actually it's a very tough to check the apex width in that patient. So it's far more tough to identify the dextrocardia only by the palpation. It's a very tough.
And sir,
so
can
you
you
will
repeat the
not
point
do
about
that.
pleural effusion? What you were saying right now? If there is
Yes.
pleural effusion,
If
then
you
we will go and check for the lymph node?
Yes. If you find this is a case of clinical pleural effusion, okay, there is a, I will say the finding, it is a pleural effusion. So just what you will do, you will try to find out in lymph node. Just you will show the examiner. It is not possible all the time to find out lymph node, but what you will do, you will try to find out the lymph node. So you will do the neck examination for lymph node.
Okay. And otherwise, should we go for lymph node examination or not in respiratory case?
No, we will not go for lymph node examination.
Okay, sir. Thank you.
Hello, sir. Can you hear me?
So, hello. Yes, I can hear you.
Sir, in respiratory station, the most of the clinical findings and diagnosis depends on auscultation, as we have ruled. Rest of the steps are just so. Please, the detailed judgment, the detailed examination of bronchiectasis, COPD, and pleural effusion. These are the common cases which are.
Yes.
Hello.
And sir, could you please tell us about different scars which we can find in respiratory station?
Okay, so now here actually we will describe the different scar only, how you will approach that. Okay, then in another session I will just in this session I will just go to the topic, just qualification, what you will say, what the finding, what is the question. In case of bronchiectasis, what is the findings, what you will say, and what will be the question. Okay. Okay, so we have discussed actually how we will examine the patient. Again, if a respiratory system examination takes time, so you have to be quick in your examination. Okay, but you have whatever during your examination, you will always focus for something. You don't miss the trachea. Okay, and focus more time on auscultation. Okay, so focus more time on auscultation and don't miss the trachea. Okay? Because those things is very much these are very much helpful. Now, actually, I will discuss today the scar cases and interstitial lunges. Hello, yes.
So, how
Hello.
we see tracheal tug? What is
Yes.
that?
Number one is that we will not see tracheal tug. Okay, it's a signs of respiratory difficulty. And in case of the tracheal tract, actually what will happen? The vocal cord will be pushed down during deep inspiration. And actually, if you want to measure the tracheal tag, you need a measuring tape. Okay, or you have to measure it with finger. Okay, and it's a signs of severe breathing problem. Those patients will not come in the exam. Number one thing. Say if a patient with a tracheal tag actually does not come in the exam. So later, what we found that patient will be comfortable. Just we'll check the position of the trachea. Any question?
Hello.
Hello.
Hello, sir.
Hello. Hello.
Hello. Sir, can you tell me how can we differentiate between ILD and pulmonary edema by auscultating?
Yes.
Because some
Okay. I will
sounds
say
are
it.
similar.
Okay. Okay. I will say it.
Okay.
Okay. I just
Thank you.
thank you for your question. I will say it later. Okay. Now, just what we are going to discuss, we will discuss the scar actually. What scar are present in the exam and what will be the finding. So, if you there are most of the patient you will found there is a lateral thoracotomy scar most of the time. So you will found a lateral thoracotomy scar. And there are some specific differential diagnosis for this lateral thoracotomy scar. And in other case, you will found some other scar. So what are the other scar? Sometimes you need to do the chest tube drain. Okay, so intercostal drainage tube in a patient of maybe some empyema or maybe pneumothorax. So there are some small scar over the axilla. So small scar in axilla for chest tube drain. Okay. And another, sometimes you will find some VAT scar. Okay. That is video assisted thoracoscopic surgery. So you may find some VAT scar, which is 1 or 2 millimeter scars. This scar actually may be some back or in the axilla. It depends on the lesion. So those are the common scar usually present. Now, the other scar maybe why? In the rare case, there may be some pneumonectomy scar. Okay, sorry. In other case, maybe due to a bullectomy scar to operate the bulla, so bullectomy scar number 1, or pleurectomy scar for a recurrent pleural disease, for pleurectomy. Bullectomy in case of the COPD patient, for to it's a lung volume reduction surgery. Okay, and in case of the Another scar for the lung transplantation. It's a very rare for lung transplantation. It may be unilateral or bilateral. So unilateral or bilateral. In case of bilateral, you will find there is a clamshell scar. Okay. Or this is the sternum and the horizontal sternum. There is some scar over the both subcostal region or 9 to the 10th rib, 8 to 10th rib. So clamshell scar. Or unilateral lung transplant may be done through the lateral thoracotomy scar. Okay, by extending the lateral thoracotomy scar, they done the unilateral lung transplant. Lung transplant actually very rare, but it may present in the advanced center actually where it is done. So what you will found most of the time, lateral thoracotomy scar. So what we will found most of the time, we will found a lateral thoracotomy scar. So this is the scar. And what at the same time, you think that this is a patient of, so if you see any patient of lateral thoracotomy scar, you will found just there is a drain tube inside. There is a drain tube. So you will find another scar below the lateral thoracotomy scar, which is very small scar for the drain tube. So it's possible you will get mostly two scars. One scar for the from the lateral thoracotomy scar just below. There is a small scar for the drain tube. Okay. Now, how we will identify actually what is the what's happened or how we will identify the scar. Okay. Just I'm going to draw a picture. If you think this is a just think that this is our lung and this is the trachea. Okay. So we at first I start from the left upper pneumonectomy. Okay, so just this portion of the lung is resected. Okay, and resected, and after that patient is discharged, and 1 year later the patient is after that call to attend the exam. So by this way, what's happened? His trachea will be already shifted. His trachea will be shifted to their side. Okay, his trachea will be shifted to their side, just like this. His trachea will be shifted. Most of the trachea will be shifted to their side. Okay. And this, what will be happen? Due to pull effect, his lung will be pulled up here. His lung will be pulled up here. Trachea is shifted there, and lung will be pulled up. And patient previously done left upper pneumonectomy. So what will be the finding? So number one, you will find a scar. You will find a scar in the left side. So what you will find, there is a scar. And if you consider above and below the scar, so in above the scar, what you will find? Look, if you are examining the patient from the front, and if trachea is already shifted in the left side, so what you will find? You will find there is a bronchial breath sound. Bronchial breath sound plus increased vocal resonance. Okay. And below the scar, everything is normal. So this is a case of upper lobectomy. So this is a case of upper lobectomy. Okay. So this is the most toughest case. This is a case of upper lobectomy. So above the scar, you will find something bronchial breath sound, and just below the and increased vocal resonance due to shifting of the trachea. And this shifting actually depends. If it is acute patient, you will not find any shifting. By the, with the time, this trachea will be shifted to the left side. And if the patient comes after years, then you will find the whole of the trachea is actually whole of the trachea is shifted to the left side, then it's shifted to the right. So there will be increased breath sound and increased vocal resonance. Okay, and below the scar, everything is normal. So this is a case of upper lobectomy. Now think about the lower lobectomy. Okay, what we will find in the lower lobectomy? Again, this is the lung, and in case of the lower lobectomy, trachea actually does not shift more. You have only done the surgery here, So yeah, if there is a no trachea. So patient has only lung there, and below the scar actually nothing. Below the scar is nothing. And trachea may shift. May shift is depends on the time or extent of the surgery towards the left. So here we have done the lower lobectomy, and in case of the lower lobectomy, what is your finding? Just above the scar, everything is normal. Everything is normal. So above the scar, everything is normal, and just below the scar, just features of effusion. Below the scar, it's features of pleural effusion. Okay, just what will be chest expansibility and movement is reduced, will be reduced below the scar, and, and along with dull percussion note, absent breath sound and vocal resonance. So everything will be below the scar. So above the scar, you will find everything is normal. Okay, you will not found any bronchial breath sound or any increased vocal resonance. So this is the case of the lower lobectomy.
Excuse me,
Now
sir.
consider if you what will be the patient of pneumonectomy. So again, if you think this is a patient of here, uh, this gentleman does not have any lung in the left side. Okay, so this is your trachea. Trachea, what will be happen? Trachea, trachea will go to the trachea will go to the left side, and then it comes to the your right side. There is an empty chest here, no lung tissue. So what will be fair? What will be you will found? And this shifting of the trachea actually depends on the time. What you will found? You will found in the there is a scar. There is a scar, and but above the scar you will found same thing, just like upper lobectomy. That means a bronchial breath sound and increase vocal resonance. And below the scar, nothing. And below the scar, you will found features of pleural effusion. Okay, so features of pleural effusion. That means both chest expansibility and movements reduce, plus absent breath sound and vocal resonance. Okay, and dull percussion note. So you will found the features of effusion. So this is the case of pneumonectomy. So this is the case of pneumonectomy.
Sir, you said below scar features of effusion, or it will be collapse?
Oh no, sorry. Just below the scar, actually, you will find the just like features of pleural effusion. That means there is a absent breath sound and vocal resonance. Okay, plus dull percussion note, plus dull percussion. So absent breath sound and vocal resonance and dull percussion. So this is the three case. Number one, again, I'm going to repeat it. If it is upper lobectomy, what will be found? I'm just saying during what I will say. I will say just like what I have done. So on examination of this gentleman, uh, most of the gentlemen will be comfortable at rest. So what I will say on examination of this gentleman, he's comfortable at rest. Okay. And in hand finding, is there any clubbing on question? I'll say that there is clubbing. Okay. And on examination of chest, it reveals there is a lateral thoracotomy scar. Okay, left lateral thoracotomy scar. Now I will say chest expansibility and movement is reduced in the left side. Okay, here left side, mostly in the left upper jaw. Okay. Now percussion note, here percussion note will be dull. So percussion is dull from the left. First, fourth is the costal space. Okay, and percussion node is dull, is fast fourth intercostal waves with increased vocal resonance and increased with bronchial bass sound and increased vocal resonance in that area. Okay. And all other area is normal. So my diagnosis, this is a case of left upper pneumonectomy. I'm saying it again. On examination of this gentleman, he is comfortable at chest. On examination of the chest, it reveals there is a left-sided thoracotomy scar, and trachea is deviated to the left side, and there is also if it is chronic case, there will be flattening of the left upper chest. Okay, in chronic case there will be flattening of the left upper chest. So we'll say it in inspection. On inspection, there is a left-sided thoracotomy scar along with flattening of the left upper chest. Trachea is shifted to the left side. On percussion, there is a dullness in the first fourth intercostal space. On auscultation, there is a bronchial breath sound along with increased vocal resonance in the first 3 or 4 intercostal space. Okay, and all other area is normal. So my diagnosis is a case of left upper pneumonectomy. Now going to the second case. On examination of this gentleman, he is comfortable at rest and trachea is central. There is a left-sided thoracotomy scar in the lower side. Actually, chest wall does not flatten. So there is a left-sided thoracotomy scar, and below the scar there is a decreased chest expansibility and movement along with absent breath sound and vocal resonance with dull percussion node. When I'm going to say the examination finding, the respiratory system, I will not say it is multiple. That is, there is a chest movement is decreased from the right fourth intercostal space to down. Chest percussion node is dull from the right fourth intercostal. I will say everything in one time. Okay. Just again, on examination of this gentleman, there is a left-sided thoracotomy scar, and below the scar, their chest movement and expansibility is reduced in the left lower zone, particularly below the scar, and there is a percussion, there is a absent breath sound and vocal resonance along with dull percussion node in that area. So my diagnosis, this is the case of left lower lobectomy. Now go to the next, that is pneumonectomy case. It will be just like upper lobectomy. So on examination of this gentleman, he is comfortable at rest. There is a left-sided thoracotomy scar along with flattened upper part of the chest wall. Trachea is shifted to the left side, and above the scar there is a increased vocal resonance. There is bronchial breath sound and increased vocal resonance. And below the scar, there is a absent breath sound and vocal resonance along with dull percussion node. So my diagnosis, this is a case of left-sided pneumonectomy.
Sir?
Okay. Yes.
Sir,
you can ask question.
Sir, you said when there is absent breath sounds, it will be the percussion will be dull, you said. But you plural if you stony dull. So I always assume that there is a signs of collapse when there is a absent lung tissue. We will find dull percussion. But pleural effusion, you said it has stony dull note. So we will get stony dull note, or we will get dull note.
Yes, you are right. Actually, it's very tough to identify stony dull or woody dull. I just here found there is a dull, but it is not characteristic stony dull. I'll find there is some dullness. Okay.
Yes, so my concept was collapse, like we find a dull note, everything dull.
Yes. That is right. Everything dulls maybe collapse or decrease, as well as in consolidation also. But here actually there will be dullness. So if you see any patient of pneumonectomy, what you will find is very characteristic that you will find there is a in this area there is an increased bronchial breath, there is a bronchial breath sound and vocal resonance, increased vocal resonance.
Sir, please.
Okay, so you may confuse.
Consolidation also, sir. Please explain. Above consolidation, what we will get?
So along with this patient consolidation.
No, sir. A consolidation case, if comes, what will be the findings?
Okay. So just if you think this is a case of consolidation, okay, just you will say always say chest expansibility is movement at the same time. Just chest expansibility and movement. Like what you say? Okay. On examination, I think there is a consolidation in the right upper or lower zone. Here there is a consolidation. So on examination of this gentleman, if you find any sign in the hand, say it better or omit it. Chest movement and expansibility is reduced in the right side. By auscultation, you know this is the right lower zone. Okay, particularly in the right lower zone. And there is a trachea is centrally positioned, and percussion node is dull in the right lower zone. From the, if you identify the intercostal space, say it from 6th intercostal space to downwards. Okay. And they along with bronchial breath sound and increased vocal resonance in that area. So my diagnosis is the case of right-sided consolidation. Okay. Yeah, trachea is central, so it is not collapse or it is not the fibrosis, and fibrosis also uncommon in that area. So trachea is central, you would say this is a case of consolidation.
Excuse me, sir.
Can you please tell the pneumonectomy again?
So, in case of
yes. Hello.
Hello.
You can say now. Yes.
Sir, can I ask one question, please?
Yes.
Sir, in these three scenarios, you said that in cases of lobectomy and pneumonectomy, we will find like bronchial breaths and increased vocal resonance. Sir, how will we find these? Because there is no lung tissue, and if there is no lung tissue, then we are supposed to find no breath sound and decreased vocal resonance, isn't it? I am a little confused about this point.
Yes, you are right. But you will find this as for the here trachea is massively shift. Trachea is shift to the right side. Okay, and I don't know actually what happened during the surgery. And here both anterior posterior side of the lung is shrunken and both close together. And due to shifting of the trachea, you will get there is a increased breath sound, there is a bronchial breath sound and increased vocal resonance there. Only this will be only localized. You will find in the only in the in the left, in case of left-sided lower lobe, upper lobectomy in the left upper zone. Here, due to shifting of the trachea, you will find this due to shifting of the trachea, the bronchial breath sound and increased vocal resonance. As just like if you put your stethoscope over the trachea, there is no lung tissue, but you found there is a bronchial breath sound and increased vocal resonance. So this is the three finding, that's upper lobectomy, lower lobectomy, and pneumonectomy. So in every care you will find the scar. So it is not simple collapse or fibrosis. It is a surgical, so pneumonectomy or lobectomy. So how we differentiate? I have already said this. So any question or any other question, or I'll go for all. Okay. So now, what are the common question in this test? So, in case of the scar, the examiner will ask the first question: what is the different? What is the scar here? So here is the scar is a left or right thoracotomy scar. So left or right thoracotomy scar. So what are the differential diagnosis of this scar? So, or left or right lower thoracotomy scar. Number one is again the lobectomy here. Number two is pneumonectomy. Yeah. Then if it is a It may be for some other surgery, that is lung volume COPD patient in bulectomy, or it may be for a single lung transplant, in very rare case, single lung transplantation. So DD of scar, lateral thoracotomy scar, right or left. Okay. So lobectomy, pneumonectomy, or bulectomy in case of lung reduction surgery, or single lung transplantation. Then examiner will ask the question, actually, what are the causes of this lobectomy? What are the, because if I say this is a case of upper lobectomy, examiner will ask what are the cause of this lobectomy. Always the number one cause is, if you see the patient, that is suppurative lung disease. Suppurative lung disease, that is either bronchiectasis, that is localized bronchiectasis with repeated infection, or patient developing complication, that means massive hemoptysis or repeated infection. So bronchiectasis with repeated infection or hemoptysis, patient develops a massive hemoptysis number. Again, now another is lung abscess. So non-resolving lung abscess, you can do the surgery. Number two is the carcinoma. In any case of carcinoma where it is operable, so operable lung cancer. So operable lung cancer, we will do the you can do the lobectomy or pneumonectomy in operable lung cancer, or pulmonary nodule, or in case of the pulmonary nodule where there is some features of malignancy. So sorry, sir, there is a feature, it may turn into malignancy. In case of the any patient with previous tuberculosis, so what's happened? Patient immediately develop post-TB fibrosis, repeated infection, bronchiectasis, and if the patient is present for a long time, there is a possibility of aspergilloma. So in aspergilloma, we can do the surgery or fungal ball. And again, of course, there is a lung volume reduction surgery, that is bulectomy. So what may be the cause? Cause is, it may be suppurative lung disease, mostly bronchiectasis or lung abscess. It may be carcinoma or nodule or aspergilloma. So those are the common causes of this pneumonectomy, bulectomy or pneumonectomy. Okay. Now, how will you going to investigate this patient? See, in every patient, we will do the same investigation in the respiratory system. How will you going to investigation the patient? So regarding the investigation, what we should consider? We should consider two things. We'll say everything, but we don't forget that spirometry and ABG. Okay, so spirometry, ABG. So what we will say? We'll do the chest X-ray, number one. Then we'll check the spirometry. We'll do the ABG. We'll check the sputum for routine and microscopic examination, as well as we will do other to see the pulmonary hypertension. We'll do chest ECG, echocardiography, and we'll do some general investigation in the other patient. So what we should not forget, that is spirometry and ABG. We'll say everything along with spirometry and ABG. Chest X-ray, sputum examination, spirometry, and ABG. Then examiner will ask the question. Okay. So what are the investigation before the surgery? Okay. Before surgery, actually, we'll do a lot of investigation. If we think that it is a case of a solitary pulmonary nodule, or then we'll do a lot of things. Just like we'll do, so before surgery, we'll do the chest X-ray. If you see in simplified manner, we'll do the ABG, we'll do the spirometry, and if need, we'll do the CT scan. We'll do the PET scan also. Okay, to effect the cardiac effect, we'll do ECG and echocardiography. And if we think this before surgery, we'll see something. What we will see? We'll see the FEV1, the FEV1, if any patient is FEV1 more than 2, on an average more than 2, then it's very safe to do the surgery. If any patient, if FEV1 2, so we can do the surgery, we can do the pneumonectomy here. But if any patient is less than 2, will not do the surgery. If FEV1. Okay.
Well, can you?
Yes, I'm going to repeat. So, so before surgery, we'll check the we will check the FEV1, FEV1, and as well as in case of the with the patient is not a malignant patient is simply COPD patient. I will do the lung volume reduction surgery, or this is a patient of bronchiectasis patient. I will plan for the surgical resection of the affected part. In this case, my target FEV1 will be, my patient should have more FEV1 greater than 1.5. Okay, and here we also do the check the transverse factor, or we'll check the good functional test status. So WHO status, functional status should be should be good, and there will be no features of severe pulmonary hypertension. Then we can do the lung surgery. And in case of the malignancy, where we are considering the pneumonectomy, then FEVR our should have more than 2. Okay, should have more than 2, and patient good functional status, as well as other features like no distal metastasis, no pleural effusion. So staging is here is very much important. Staging. Okay. Now, how we are going to manage this patient during the how we are going to manage this patient? Again, patient education, counseling, explanation of the disease, formation of the multidisciplinary team. Here we will say something, 3 things extra. Like, well, ask the patient to stop smoking. So ask the patient to stop smoking. Number 1. Number 2 is vaccination. What is vaccination? The pneumococcal vaccination. Pneumococcal and influenza vaccination. Someone also prefers seasonal influenza. Okay. And lastly, pulmonary rehabilitation. So pulmonary rehabilitation. So I will say that I will do non-pharmacological at first. That means patient education, counseling, explanation of the disease, formation of the multidisciplinary team, and stop smoking, vaccination, and pulmonary rehabilitation. Okay. So these are the management. And actually, this patient, in case of the simple lobectomy or pneumonectomy, there is if the patient does not have any other problem, we don't need to do any other thing. Just we'll do this simple management. So I'll stop smoking, vaccination, and pulmonary rehabilitation. This is the most important part of management of respiratory system. So any question? Is the management. So any question regarding the scar? Any question? Hello.
Today we are here to about your condition. Is it okay for you? Yes, please. So, Mr. Stewart, it came to my knowledge that you have suffered from increased frequency to go to toilet for urine. Would you please tell me more about your company? Have you experienced this problem?
Hello. So this is the common scar present in the exam: pneumonectomy, lobectomy, and pneumonectomy upper or lower lobectomy. And at the same time, we will look for the any scar for the chest drain or Baird's scar along with that, because it's may present before doing the pneumonectomy or lobectomy. The patient usually undergo Baird's surgery to do some pleural biopsy or some other thing to identify, confirm the diagnosis. After that, surgery is done. So there may be one large scar along just below the scar. There may be 2 or 3 small scar. Okay. So any question?
Doctor, what will be the pulmonary function test in pneumonectomy? It is a
Sorry,
restrictive or
sorry.
pulmonary function test?
Yes. Regarding the pulmonary function test, actually pulmonary function is assessed by picrometer as well as spirometry. So you can do the both picrometer or spirometry. There are also some advanced pulmonary function tests, but here we only say two things: picrometer and spirometry. Okay, along with
what will be in
just it's a
pneumonectomy?
broad term.
The result.
Yes.
What will be the result of pneumonectomy, the pulmonary function test result? It is a restrictive type or?
Yes, a good question. It will be
Obstructive type.
restrictive type. A restrictive type.
Restrictive. Okay.
Yes. So in a pulmonary function test, we will say all the tests apart from this. So we'll do some basic tests. We'll do X-ray, CT scan, spirometry, picrometer. So if there was sputum examination, bronchoscopy, bronchoalveolar levels. So in this way, I will say the investigation. So any other question? So, okay, so thank you everybody for the participation. We will discuss the other station. And we'll put a like pulmonary fibrosis or DPLD, and pleural effusion. That means we will discuss the COPD and bronchiectasis in the next. So, thank you everybody for this participation. Assalamu alaikum.